welcome all. If you could all hear me. Hello. My name is Kat. I've been here for about 4 years now. Previous to this, I was in one of the teaching hospitals in London. So my remit when I started was to start a paediatric dental unit. So my specialty is paediatric dental. And for my sins now, I've become the lead for all of dental and maxillofacial, purely because there's nobody else. One of those things you jump into. It's a privilege really to work in such a great hospital, and I honestly believe that. So there's always a misunderstanding about what dental is, and exactly hospital dentists, community dentists and stuff like that. So we'll quickly talk about a little bit about peds first, then the generality of the stuff that you see rather than us. So dental maxillofacial is split into different subspecialties. So you've got adult special care, so that's anybody over the age of 16 who has special care needs, be it physical, mental or medical. Oral maxillofacial surgery, these are the big boys, these are the surgeons who do all the trauma, oncology work and so on and so forth. Orthodontics, these are the people who do the braces. Primary care is all named for the community dental surgery. Community dental are the GPs, they do all of these subspecialties and they do well. Pediatric dentistry, anything from 0 to 16. And restorative, these are the crown and bridge guys and girls. So all of that amalgamates into the dental maxillofacial unit. We don't have all of these subspecialties on site, but we have the skills and referral pathways in place. So hopefully we'll go through, as I said, what we do, what we don't do, and how you guys are going to fit into that equation, and also safeguarding, because a lot of the stuff that you do has a safeguarding element to it potentially. Bog standard decay, it's still around, it will be around for a long time. It's like any preventable disease, it needs patient, parent participation to prevent. People aren't engaged, you're going to get disease. Okay. And we see a lot of neglect. Neglect's really hard because it's like basically telling somebody how you should parent or not parent. So, and there's no law against being a bad parent as such in general. There's specifics of bad parenting. So the issue we have is, people do make mistakes in parenting, like anything in life, is not to be judgmental, but try to help them. But the persistent failure of parenting, not the first kid, but the second, the third, fourth, all having GA, you've got to say to yourself there's something fundamentally wrong. Okay. This is what we love to see, and we should see in Surrey. We're in one of the most affluent parts of, dare I say, Europe, while we're still in it, and Britain. We're a first world country, but we still see preventable disease. So dental decay, 99.9% is preventable. Okay. But we see this day in, day out. This is chronic, it's not acute. This has been going on for a long time. This child is in pain or has been in pain, has needed antibiotic unnecessarily, missed school, parents missed work. There's a catalogue of issues around this. This child is burdened with ill health. That burden can be alleviated in the short term by treatment, but there will be a burden of care on that child later on into adulthood. Anxiety being one of the biggest ones. Lack of access to dental care in certain areas, and also needing more complex works later on, such as brace work, which is unnecessary. And the consequences can be devastating, Nasty abscesses are life-threatening, especially if you're immunocompromised. Even if you're not, there's been reported deaths in children. It can happen. We also see just neglect. You're a special needs child or an adult, and in a care home, people don't look in the mouth. You don't have to be a dentist to look in the mouth. You're a medical professional, be it nurses or clinical, medical staff, sorry. Do have a look. This is a child I saw on our road because of a dog bite. Very innocent dog bite, there's nothing else, but we do see some of these things. Child tripped over a dog lead. The issue is not the treatment, but finding treatment. So in this area, I'm the only consultant, which is unfortunate because my colleague in Brighton's left now. So Brighton hasn't got anyone. All of Kent hasn't got a consultant in care. I'm not saying consultant-led care is a be-all and end-all, but there's a reason you go and see a consultant. And this patient went around the house and we found it, and the treatment itself was straightforward because we have the mechanisms in place to deal with that. This best question I get is why bother with children's teeth? Because you get a second set. It's a reasonable question. And it's not just the public, it's medical profession and dentists ask that. It's simple quality of life. Just because you're a child doesn't mean you should not get a quality of life. All the research has been concentrated on adults and quality of life because they vote, they pay taxes. But children should count more because they're the future. It affects the growth and development. If you've got raging toothache, you ain't going to eat. You ain't going to nourish yourself, you'll be dehydrated. It is a lifelong impact. If you see any of your colleagues who are phobic with dental treatment, if you drill down, there's some history. And the history is a negative perception of dentistry because why go and see a doctor when you have an MI? Why don't you prevent the MI? Makes sense, right? Because long-term viability of that individual is greater with preventions now. And the burden of healthcare, everything comes down to money. If you could prevent something with a toothpaste, which can be free, toothbrush, which is less than £1, and it's a medicine and you have to take it twice a day, that's what we instill on our parents and caregivers. It's important. It's a fundamental part of life. Nationally, we've got huge challenges. There's not many dentists around who are specialists at long consultants. Dental decay, we know since the 70s, has drastically dropped because of introduction of toothpaste and fluoridated toothpaste. But we still have like many chronic health problems like diabetes, COPD. There are regional inequalities. By that I mean 80% of the disease is in 20% of the population. So we're in a really affluent area here, but if you go just down the road, you may not be in an affluent area. It's always in the news, but it's, yes, we're bombarded now. It just becomes like end of the child death thing. It just doesn't trigger those emotions that it should. This is the shocking statistics. Nearly 46,500 children under the age of 19 admitted to hospital through A&E mainly. Main reason, dental. The only reason, dental. The largest number of operations done on a child is for dental treatment. Not ENT, not trauma, but preventable disease. And it's the only specialty where you could go under the knife by a non-specialist in that area. So if I want to get my cardiac stuff done, it's like a GI surgeon working on me. It just doesn't make sense. Okay, the results aren't going to be good, are they, really? So the repeat rates of GA or day case anesthesia is what we're really after. And we looked at it, we drilled down the data since I started, and our repeat rate is 0.8%. Why is it? It's a team effort. We make sure we triage them, screen them, we do x-rays when they're awake or when they're asleep, so we're not missing anything. We're strict on what we do. Doesn't mean we take out every teeth. That's one way of getting rid of the repeat rates. We fill and we fill, but we do good fillings, white fillings or metal crowns. So the biggest issue is prevention. Trauma is suboptimal care. I did a talk to your colleagues at CCAM, I believe, in Denham House. There's no specialist input, and trauma is time critical, especially if you're not the tooth. I'll come back to that in a minute. You need to find the right person at the right time, and you're not going to get that. Dental anxiety. What are you going to do with these children who are extremely anxious? They're not going to go to a dentist, so it gets worse and worse, and they get rushed into A&E, facial swelling, GA if they're lucky, then they're more anxious. Safeguarding is always at the cornerstone of this. So this is where you are. These are the big players, William Harvey, QVH, and so on and so forth. We're just nestled here somewhere. If you look from Bognor to Margate, there's not another consultant. Brighton did have one, but they lost that consultant. The next port of call is St Helier. Then it's London hospitals. London hospitals are very busy. They are the tertiary centres in many cases, so they are limited in the numbers of vacancy. So at the moment it's me I did have a STR, but she's finished the training, hopefully will come back. We are multi-agency, so we deal with other colleagues, medical and non-medical, and have an extremely large catchment. So who comes to see you guys? All of these wonderful people living their normal lives and doing not so normal things. Biggest things that you may see are dental infections. The spread of dental infections, not toothache, because that's not an accident or an emergency, as I keep on telling these people. Those emergencies where there's a compromise to that individual's health on ASA grading, really. And it's simple treatment that's needed, which is drainage, if possible, or extraction, removal of the cause, under local or general anesthesia, analgesics and rehydration. Antibiotics, we don't throw antibiotics at dental, it just won't work. You need to get rid of the cause of the problem. The only reason you will consider antibiotics very strongly is that the immune status is compromised, or the vulnerable individual, or there's a spread of infection. Okay. But there's no point, antibiotics is part of the package. You don't give and forget. The patient needs to be seen for adequate treatment and review. Airway compromises, we see more than we should do through you guys. An appropriate treatment without misuse of antibiotics. Dental trauma is the other big reason these patients are seen by you guys. It's unpleasant, it's stressful. But I think of all the departments I worked in, the ED here is pretty good actually. They just got their thing together. They found out where the deficiencies are and they've done something about it. One of the things I always ask is, have a look in the mouth. Are the teeth already there? Everybody knows what a tooth looks like. Everybody knows when the tooth is half broken. Where is the fragment? Is it in the lip? Or is it somewhere else? It does happen. So the red ones are the ones which need treatment straight away. So before I start this, you know that our relationship with one of the maxillofacial providers, Queen Victoria, which has been great, just things haven't worked out well, and we have now have a new relationship, if that's the right word to use, with Royal Surrey. They're great surgeons, like the ones in Queen Victoria Hospital, and it's early stages in the relationship, and there have been some teething problems like any relationship, but it's been ironed out. And one of the questions Peter asked me was, what do we do with avulsions? So initially we're going to talk about adults. Adult teeth being knocked out, usually it's the front ones, it's time critical that they're reimplanted. And if you guys are happy to reimplant it, please do so. The medium of choice for the parents when they bring out is milk, or the parents could quickly clean it with some water and put it back in. Okay. We've got a poster that should be in your unit that was done about 2 years ago. There's copies if you want more. I spoke to the lead consultants in Royal Surrey and they're aware of this. If you have an adult tooth that's been knocked out and you need them to be seen straight away, they know it's time critical, you know it's time critical, you need to press it on them if they don't know. If the SHO is being reluctant, you go up to the registrar or even the consultant. As far as they're concerned, they agree with it, they want to do it, and they think they will. It's no point putting it back in, it needs to be splintered. It's like if you had really bad fracture, it needs an orifice. You can't just click back and say, off you go. You need something done about it. Okay.
Can I just ask you, there's been a few people that I've seen and people have put them back and they've done it, but round the wrong way.
Do you know what? You're
and
stuck.
You're
stuck.
Do you just leave it there or you
Have you actually seen that?
I think you might have to. Depends how long they put it in. You could put it in again.
They've got it back. I'm thinking, oh no.
Because it comes down to that stress, doesn't it?
Yeah.
You can see how that
You
is.
just don't know. It does happen rare. If it's really fresh, you can just put it back and put it back in.
Yeah.
But if you're confident enough to do it. So these are the ones that need treatment. The golden time is 5 minutes.
Goodness.
Or
5 minutes
to put it back in.
For them.
Because the cells
The point is that coming out.
Yeah. So when they ring and the tooths come out, one, find out if it's a child. If it's baby teeth, never, ever, ever re-implant. I took one to theatre the other day and I take it out because somebody stuck it in. A dentist stuck it in. You shouldn't. If it's an adult tooth and they're not medically compromised, so if they are undergoing chemo or they've got some serious cardiac issues, you've got to tell yourself, is it worthwhile introducing factory repair? The answer is no. Yeah. But if they are fit and healthy, generally, ask them to re-implant that straight away. If they can't, put it in a storage medium like that. The poster should be at the reception, really, because they get it, or whoever answers these phone calls. But sometimes teeth are not the main thing, you know, they've got some life-threatening injuries, and teeth do get full, which is sad.
Can I just ask something, because you're on that subject,
Yeah.
can they put it inside, they've got nothing with them?
You can do, but the risk is they swallow it.
I know, no.
That's the only thing. Or aspirate.
Yeah.
This is the one designed by us a while ago. Act fast to make your tooth last. Bit cheesy, but it's cute. First thing is pick up the tooth by the crown. Okay, don't touch the root. And people should know what the outside and the inside is. But like you said, when it's covered in mud or blood, it's different. Okay. The ones which are yellow is a traffic light system.
Just sorry, Kat. Just back on the last week. So obviously, with an adult tooth, the objective is to re-implant. With a child that has knocked a tooth out, nothing conservative.
But they'll probably
Yes,
need an
they're
X-ray.
secondary.
Yeah. The reason with the primary teeth we don't put it back in is the likelihood of failure is great, as in adult teeth. But in adults, we hope that they're compliant enough for treatment. Whereas you're subjecting a child automatically for a general anaesthetic when it's not needed.
Yeah.
What I would suggest is that a child who has knocked a tooth out keeps that tooth, goes and sees the dentist to make sure there's no fragments left behind. They'll need a proper assessment, including an X-ray, and they'll need monitoring because there's potential for damage to the underlying adult.
So would you suggest that we tell the parent to go to the dentist for that?
Always document that you've done that, because
we shouldn't be open.
We should be X-raying with here, or should we?
no, because
that's
every
right. They
time
can't see them.
what I would say to you is,
Unless they've got bony
why would you do a
pain.
test
No.
if you're not going to activate it? So the answer is no.
Yeah.
I suppose if they've got bony tenderness around the maxilla or the mandible,
Then it goes to
you're
the
gonna
maxillofacial
X-ray.
unit at Royal
Yeah.
Surrey. You ring
Okay.
them up and say, look guys,
They've
this
knocked
is
the
the
tooth
thing.
out and
They'll need an assessment and they'll make a call if it's a red, amber or a green. Yeah.
they've been very good, to be honest, when I've phoned.
They've been, but it's like any relationship, it's nice and gentle.
Yeah.
And if you fall, find out why, pick it up. These are luxation injuries. Luxation, as you well know, in joints are, movement of something within a confined space. And a tooth is in a confined space. It's got some ligaments around it and it gets knocked and jarred. These need to be looked at fairly urgently by a dentist. So the ones that you may see are where the teeth have been pushed back. Adult teeth, let's talk about adult for the time being, and they can't bite together or in the wrong position. They need that repositioned and possibly splinted. There might be underlying fracture of the alveolus as well. Okay, so once you are happy from a A&E point of view, head injury point of view, then that call should be made and transferred.
So I've seen some children.
I'll talk to the children in a minute.
When they fracture the teeth.
Yeah, I'll come to children in a minute. So let's talk
So
about adults.
with this cat, do we say need to be referred not to their dentist or to Guildford? for
It depends
this?
how bad the injury is. Okay, so if somebody comes in and the teeth are pushed back, like you mentioned,
45 degrees, yeah.
that needs sorting out soon.
Fine,
You
okay.
can't wait. If somebody's got slightly loose tooth, that can wait.
So that could be
A dentist.
Dentist, their own dentist or
One of the things you can do is I'm here Tuesday to Friday, or my colleagues is. If you're not too sure about something, call us and we'll say, this is what I mean needs done now.
Okay.
This is what I mean. That's the only way you're going to learn, and I'm going to pass in information.
Okay.
Yeah. Green, you can wait a little, again monitor it. Usually the hard tissue injuries, bruises, tooth being slightly knocked in, but only a little bit, compared to the one next to it. Generally good prognosis, but again needs to see a dentist at some stage. Children, different ball game. Okay, they're usually traumatized by the whole trauma. That's the right word. They'll remember what happens to them quite well. So it's important that this is made as pleasant. So pain relief is fundamental. And you need the parent or the caregiver to be part of the team in order to fully examine. The ones where you need treatment are when there's been some severe fractures. Alveolar bone definitely needs to be sent to Rolls-Royce straight away. There's root fractures and really wobbly teeth. And if they're really that wobbly, they'll need something done sooner than later because it's an aspiration risk. If the tooth's just hanging by a thread, extruded, it needs to come out. You know, if it's really that loose, you can just pluck it out if you can. If not, they need to go for a short day case or C-pod list and also. If the tooth are pushed back in or the patient can't physically bite down, again, these need to be sorted sooner than later. Alveolar is just the bone that supports your teeth.
So the children I saw came on a weekend, but actually had the injury on Friday or Thursday before, and he had lost his tooth. He just hit up as on sports and it fractured right across the. He didn't have his piece of tooth. He just had this stump.
That needs to be sorted sooner than later.
And that was like 3 days later.
Yeah, so that falls into the area where it's polyamber.
Yeah.
They're okay now, but again, they can't stay like that because they're infected and access. They'll need a proper assessment if there's any underlying problems. Where it's amber is an intrusion. Baby tooth been intruded a little bit. In those cases, I usually wait. They do come back down. Not all the time, but they do. Here, they need to see their dentist. Unfortunately, if it's knocked out, fine. Make sure there's no other injuries. See the dentist for an X-ray to make sure there's nothing left behind. If it's been slightly moved, but they can still bite together, leave it well alone against the dentist. So you're going to just make it clear if you're tweeting that it's paediatric now.
Yeah.
Was
so the flowchart for avulsion was adult.
It's adult.
And
All
it's
of adult.
paediatric, yeah.
So the ones for peds where you can say, look, you can take your time, find a dentist in a week or so, a couple of days, is where the fracture just involves the white part of the tooth, which is the enamel or the dentine, but not the pink part, which is the pulp. If there's a root fracture, how would you know? Without an X-ray, but let's assume it is, but there's no movement. Concussion, it's given a nasty knock, feels a bit tender, leave it alone. Some luxation again being slight movement within the socket, keep an eye on it. Does that make sense? Yeah. These are the big things. You rarely see this in children, mainly in adults, but again, any facial fracture you're suspecting, phone call, images downloaded to Royal Surrey assessment and they'll run with it. Orbital blowout fractures especially, you're used to these stuff. Again, the pathway is Royal Surrey. The 4 fractures, good imaging, chat with the reg on call with the SHO and transfer the images across. Same thing with mandibular fractures. I put it in there just for completeness sake. Any facial fractures are the ABCs really. And this is where the maxillofacial consultants and registrars will jump in, make sure they get appropriate care and follow up as well. Okay? If there's any tests needed, they will be able to facilitate that. So, safeguarding in children, but there's safeguarding in adults as well. We'll talk about the children's part here. So why is it that you should think about safeguarding in dental stuff? Because most of the time, there's injuries that happen are head and neck injuries. If you think about it, okay? If you're going to hit someone, a child, the height is around about your waist or their head. the trauma they get is usually the facial. It's the most exposed part. You have a great system here where a child of a certain age presents, it's automatically reported to safeguarding. It does sometimes feel like Big Brother to certain people, but it's just the only way you can deal with these things, because you need a safety net, and that's all it is. Most of the time, it's innocuous, innocent stuff, and you pick up stuff otherwise wouldn't have been picked up. So it's a great service that you do. From your point of view, history is fundamental. What happened to Johnny? Ask Johnny as well, then ask Mum. It should be consistent. Bearing in mind the stressful situation, people might get certain things mixed up. But you know your gut feeling that something isn't right, you need to delve into it. And also, if you're not too sure, just involve safeguarding. They'll just look into the file, see if there's any other concerns that are important as well. These are not pleasant pictures, but if it's too much, just let me know and I'll stop. The things that we see with regards to abuse are bruising and rarely fractures. Bruising of different vintages. You can't really age bruising as people used to think, but clearly there's a history of assault in that region. You can't see the slap marks, but you can see fingers across. I always say, look behind your ears. You know, if you're somebody who's got long hair, just pull the hair up. You're going to see some mastoid bruising and base and skull fractures. The only way you're going to see that is by lifting it up. If somebody's got a veil on for registries on it, you just ask them, because you're doing your job to work. Because otherwise these are the sentinel signs that are sometimes missed. Bite marks. My kids used to bite each other emotionally. It's a normal part. But you still need to find out when did this happen, where did this happen. And inside the mouth, it's just bruising and stuff like that. Torn freedom used to be taught a long time ago as being purely pathognomonic of abuse, but it clearly isn't. If you've got children and they fall, the freedom's got fragile it goes. But it forms part of a picture. Again, the history surrounding that individual and the family is key to that. We're getting there. I think with all your help, we'll make it a better place for children. I know you're videotaping this, but this is not going to go to anybody else, is it? So fine. Any questions?